I'd like to thank the America's Hernia Society and the Quality Collaborative for the opportunity to present our randomized controlled trial of heavyweight and medium weight mesh in open retromuscular ventral hernia repair. We have no disclosures. Mesh reinforcement has become the mainstay of large ventral hernias since the landmark paper by Lewandijk, who demonstrated a significant reduction in hernia recurrence with mesh reinforcement. There are a multitude of mesh products on the market with a wide array of mesh properties, including fiber type, construct, pore size, and mesh weight. To date, there has been little evidence from randomized controlled trials to guide surgeons on their choice of mesh based on these properties. Given this, we set out to perform a randomized controlled trial that would address the impact of one of these properties on hernia outcomes. The aim of our study was to investigate the impact of mesh weight on clinical and patient-reported outcomes following open retromuscular ventral hernia repair. To do this, we performed a multi-center randomized controlled trial with 4 centers throughout the United States, as well as 10 surgeons performing the operations. The study began in March of 2017 and took just over 3 years to complete. This trial was embedded within the AHS-QC and supplemented with REDCap. We included patients who were getting an open retromuscular ventral hernia repair utilizing polypropylene mesh. For mesh weight, we determined a medium weight mesh was between 40 and 60 grams per meter squared, and heavyweight would be considered anything greater than 75 grams per meter squared. We included elective cases that were clean as determined by CDC class 1 wounds. The defect size had to be less than 20 centimeters wide. Patients had to be over the age of 18. We excluded any patient that we could not achieve fascial closure on, and anyone who had any degree of contamination as defined by CDC class 2, 3, or 4. Our primary outcome was pain 1 year after ventral hernia as measured by the NIH PROMIS pain score. Our secondary outcomes included 30-day wound morbidity, 1-year hernia recurrence, and patient-reported outcomes. Patient-reported outcome measures included Hercules, a 12-question disease-specific quality of life assessment tool, as well as patients being asked 1 year after surgery whether or not they could feel their mesh. To determine an appropriate sample size, first we set a clinically meaningful difference of 30% between heavyweight and medium weight NIH PROMIS scores at 1 year after ventral hernia repair. We then performed a two-tailed calculation with a type 1 error rate of 0.05 and a power of 80%. Based on this, we needed 320 patients to demonstrate significance. Assuming a 10% long-term loss to follow-up, we set out an enrollment goal of 352 patients. In total, we enrolled 350 patients, 173 within the heavyweight group and 177 within the medium weight group. After randomization, we had similar baseline characteristics, including similar rates of BMI, diabetes, ASA, hernia recurrence, and modified ventral hernia working groups. Similarly, within our operative demographics, there was equal rates of prior mesh and similar operative times. Our overall hernia width for heavyweight was 14 centimeters and medium weight was 15 centimeters. In terms of wound morbidity, overall surgical site infection rates were similar between groups, and there was no difference in depth or degree of the infection. 5 patients in the heavyweight and 9 patients in the medium weight group required a procedural intervention for their surgical site infection. Looking further into the surgical site infections requiring procedural intervention, most importantly, only 1 patient required partial mesh removal within the medium weight group, and no patient required complete mesh removal in either group. Additional 30-day outcomes included the surgical site occurrence and surgical site occurrence requiring procedural intervention, and there was no difference in these groups. Overall length of stay was 5 days for both groups, and similar rates of reoperation and readmission for both groups. For our primary outcome measure of pain 1 year after the operation, we use the NIH PROMIS score. Using this, we can see similar rates at the baseline PROMIS scores. 30 days, though this did not change much, but by 1 year, we showed a significant reduction in overall pain from the operation. However, there was no difference between the heavyweight and medium weight groups. This trend was similar within the Hercules evaluation, with similar baseline characteristics and 30-day outcomes, with a significant improvement in overall quality of life at 1 year after the operation, but no difference between groups of heavyweight and medium weight in terms of the degree of the overall improvement in quality of life. Regarding mesh sensation, 21% of patients said they could feel their mesh 1 year after hernia repair. There was no difference in mesh sensation between groups, as both groups had a rate of 21%. Hernia recurrence was measured in multiple forms, including physical exam, radiographically through CT scan, and then utilizing the ventral hernia recurrence inventory. Within the ventral hernia recurrence inventory, which is a patient-reported outcome measure to identify potential hernia recurrences, if a patient says that they feel or see a bulge, the hernia would be considered recurrent. At the 1 year mark after surgery, the overall rate of hernia recurrence through physical exam was 1% in the heavyweight group and 2% in the medium weight group. There was a slight increase in hernia recurrences when evaluated radiographically, with rates of 3% in both the heavyweight and medium weight group. Utilizing the ventral hernia recurrence inventory, there was a significant increase in identified hernia recurrences, with 30% within the heavyweight group and 35% within the medium weight group. Regardless of which technique was utilized, there was no significant difference between heavyweight and medium weight in terms of overall 1 year hernia recurrence. In conclusion, in a randomized controlled trial, there was no difference in clinical or patient-reported outcomes at 1 year when heavyweight or medium weight polypropylene mesh was used for open retromuscular ventral hernia repair. Thank you.